Thank you, Mauricio. Ladies and gentlemen, it's actually a great pleasure and honor for me to be here today and to discuss with you might be in the coming years the machines, the devices who might be used in patients with shock. So this first my COI slide. So 2017, now, which pump, which device should be used? Also, of course, we have ECMO, which has been used a lot in the past decade, but we might have other device coming to the market in the coming years. So what will be the indications and the machines? The indications, we have the classical indications, those who have been used for decades in cardiac surgery. Patient might use these devices, machines, as a bridge to recovery. If, for example, the patient has myocarditis or a bridge to bridge, you first use the first machine, then go for a bigger one. Or you might use these machines as a bridge for transplantation. Might also be destination therapy. It's this case for VADs. Not that many in Europe, but now in the USA, half of the VADs were installed in these patients are for destinations. There's no plan for other treatment beyond that insertion. So this is the classical indication. But now, talking about patients, our patients in the ICU, in the acute care setting, these machines might be used as a bridge to decision. Patients are very sick. You set up a machine, and you might then go for recovery, bridging, transplantation, and also in some patients, hopefully they might recover, but some of them might not recover, and you might just withdraw the machine after a few days if the patient, for example, has developed a severe multiple organ failure. So this is here on the left side of the panel, the Intermax classification, which is used in the US for the indications of VADs. Most of the patients who got the VADs are Intermax 2 to 4. Here we're talking about Intermax 1, those who have critical care, critical disease, critical cardiogenic shock, and even those who might be here in the zero state, those who are already dead, those who get the machine under cardiac arrest. So we have short-term devices and the big devices, the VADs. Clearly now, the VADs are not for those patients in the setting of critical cardiogenic shock. These machines are very expensive, 60,000 to more than 100,000 euros. So this machine should be for stable patients, for sure those in class, Intermax class 2 to 4, but clearly not for the acute setting. So we have these smaller machines which might be used in these patients. First, the balloon pump. The balloon pump has been around for decades, more than 4 decades actually, but that's bad news, very bad news for the balloon pump. This was the results of the Shock 2 trial. The landmark paper was published in 2012, and this is in 2013. The long-term outcome of the balloon pump, you see here mortality at 1 month, 40%, at 1 year, 50%, and no difference between the two strategies, the control group and the patients who got the balloon pump. So following the publication of that paper, the indication was downgraded from a grade 1 10 years ago to a grade 3 now. There's no indication for routine use of the balloon pump in patients with cardiogenic shock. Might still be discussed in specific population of patients, but I guess that in 5 years from now is going to be a class 3 recommendation for all indications. So the balloon pump might belong to the Museum of Medicine together with the iron lung and the swan guns in the coming years. Yes. The problem is that for now, the evidence favoring the use of these machines is very low. So in the same guidelines from the European Society of Cardiology, the short-term mechanical devices only got a 2B recommendation. That means that you might use these machines, but the evidence, the scientific evidence is still quite low. We have other machines. This is the tandem heart, not available in Europe right now, but it's available in the US. This machine here positions a cannula in the left atrium through a transseptal puncture. And there is a central pump here which propels the blood back to the patient into the aorta, the lower part of the aorta. Some complications and some troubles with this device, mainly related to the transseptal cannulation, which is not that easy. It needs a lot of experience. Some patients also might got residual atrial defect. The flow might not be sufficient also in some patients. So the machine is still used in the US in many centers, but once again, not available as of now in Europe. The other type of pump which are available worldwide, including here in Europe, is the Impella family. The principle is just the same. It's a catheter-based pump which is inserted backwards into the aorta here, and the extremity of the pump here is positioned within the left ventricle. It sucks the blood here from the left ventricle, and it propels the blood here in the proximal aorta. This is here the small one, which is called the 2.5, which might deliver up to 1.6, 1.8 liters per minute. This is the modification of the small one, the CP. It can deliver up to 3 liters per minute. It has been CE marked in Europe 3 years ago now. And we have the big one, the 5.0, which needs surgical insertion, usually here through a subclavian artery. And the principle is just the same. It's positioned here within the left ventricle. This one is quite big, can deliver up to 4 liters per minute of blood flow. There's some problems also with these pumps. The first one is the cost, between 10,000 and 15,000 euros. It's a lot of money for a device which will be used for just a few days. Much more expensive than the balloon pump for sure, but also ECMO devices. There's been concerns also about hemolysis with this type of pump. And there was a publication a couple of weeks ago of that paper, which is a small RCT showing that there's no difference between the IABP and the Impella CP in patients with acute MI and cardiogenic shock. So quite disappointing because this device clearly delivers some blood flow, which is not the case of the balloon pump, but there was no difference in here in terms of mortality. This is the other one which might reach the market in the coming months. It's the HeartMate PHP, which is also a catheter-based pump. The pump is mounted here on the big stent, which expands at the level of the aortic valve. And the pump, when it's open here, has a 24 French profile, so it can deliver up to 4.5 liters per minute of blood flow. And the insertion site, it's only 13 French, so it can be inserted easily percutaneously. No data as of today with this pump. And the other major drawback of the Impella, of the PHP, is that they only drain the left ventricle. So if the patient has severe biventricular failure, this might be a problem here. There is a new Impella for the right side. It might be used in combination with those on the left side. But it's a two-pump, and the cost is more than 20,000 euros, once again, just for a few days. And then we have VA-ECMO. It's probably, as of today, the most used device in this situation of acute and critical cardiogenic shock. These are data here from the ELSO registry showing that the steep increase in the last 5 years of the use of these machines, at least the cases reported in that registry. Why is ECMO used so much as of now in these patients? It's probably because it's the easiest way to support the vital organs of the patients. It can be implanted very easily, including at the bedside. For now, we use this machine with percutaneous cannulations, might be used very easily under echo guidance, and it provides very high and stable flow. And the cost is much less. The cost of a pump is between 1,000 and 2,000 euros. So it's much less than the Impella, for example. What are the results? Now, let's review a little bit the literature on the subject. There's some kind of accepted indication for those patients who are clearly refractory to medical treatment, patients with acute MI, cardiogenic shock. This is probably the paper with the highest level of evidence, but still very low. It's a before and after study comparing 25 patients here with profound cardiogenic shock refractory to medical treatment at a time where that center did not use ECMO in this setting. Mortality was more than 70%. It dropped down to less than 40 when they decided to develop and to initiate an ECMO program for the same type of acute MI patients. So the Kaplan-Meier is impressive, but once again, you should be very careful because the biases here are quite high because of the design of this before and after study. This is one of the most recent study by our group in France together with another group in Brittany, showing that we might reach now survival close to 50% in these very severe cardiogenic shock patients. We all were refractory to a medical treatment. And the good news is that for those who survive, we were able to win them from the device. More than two-thirds of them, two-thirds of the survivors were able to be weaned from the machine without the need for bridging to a big VAD or bridging to transplantations. Probably because heart sedation was mainly involved here in the development of severe cardiogenic shock. The other population of patients also will clearly benefit from this strategy is those who have end-stage dilated cardiomyopathy. This is a new series also by our group of more than 100 patients who arrived in our department with end-stage dilated cardiomyopathy, and we were also sliding on catecholamine, developing shock with high lactate. And of these patients, more than three-fourths of them were bridged with ECMO to transplantation. Of course, they were so sick that some of them died, but overall, we got close to 40% survivors using this strategy of bridging them either to transplantation or to another machine with the intent to transplant them after stabilization, after a few weeks or months. Once again, when looking at the predictors of the outcome of these patients, the SOFA score, for example, was highly predicting of the poor outcome for those, especially we had a SOFA score over 14 initially, as also was the case of high blood lactate when they arrived in the ICU. The other type of patients who might benefit a lot from the strategy is patients with fulminant myocarditis. This is probably the population who will benefit the most of the technique. We are talking about very young patients. None of them are pre-existing comorbid diseases, or very few of them. And this is a series of 41 patients. And of these, we got more than two-thirds of long-term survivors with this strategy of early VA-ECMO. And then some of them needed a bridge to a heart transplant, but most of them surviving without the need, once again, for complicated heart surgery or complicated transplantation. Another population which is very specific, those patients in heart surgery department. ECMO has completely modified the way we treat these patients. Once again, looking at the latest ELSO database, you can see there is a steep increase here in the use of these machines in the setting of cardiac surgery. This is the biggest study published so far, still a bit old now, It's patients from the last decade, and probably there's been an improvement in the care of these patients. So in that paper, the mortality was quite high during the first few days, but for those who survived, there was close to 20% survivors. Those who survived had a very good long-term outcome. So it should be re-evaluated in the coming years. Heart transplant, also a very specific population of patients, but that's completely modified the way we treat these patients, both to bridge them to transplantation. We can bridge patients, for example, patients with severe acute MI, which does not recover, might be bridged to transplantation with peripheral VA-ECMO. And it also has completely changed the way we treat these patients following transplantation. Those who have primary graft failure, 15, 20 years ago, when there was no these type of machine available, there was only one option: retransplant, or get big total artificial heart. The VAD or small VADs were not available, and for those patients who had severe primary graft failure, there was no option: death or this complicated strategy. And now with ECMO, once again, we can bridge these patients to recovery. There's a lot of grafts which might recover in a matter of a few days following the insertion of a machine. So these were the so-called accepted indication. Once again, despite the fact we lack a lot of scientific evidence. And there's new indications, emerging, trending indication. We might go for ECMO or other types of devices much early on in the course of the disease, especially for patients with acute MI. It's probably the largest population which might benefit for VA-ECMO in terms of numbers, and we might go for ECMO before the patient develop refractory cardiogenic shock. Once again, these are data from the SHOCK 2 trial. Mortality at 1 month is 40%. There's room for improvement here. We might decrease mortality by half if we are able to set up a device very early on in the course of the disease. Here is the Kaplan-Meier of our ENCOURAGE cohort. Those who are refractory, of course, mortality is higher, but not that significantly higher. And when looking here at the two different populations of patients, our patients here who got refractory cardiogenic shock were very, very sick and much sicker than those who got the balloon pump in the IABP SHOCK 2 trial. So there's clearly room here for new trials evaluating this strategy of early mechanical device support in this type of population. Another type of population which also might benefit from this type of treatment is those who have septic shock. Not all septic shock patients, of course. Patients who develop severe heart failure, severe left ventricular failure in the setting of septic shock. This is a small number of patients. This is a niche indication, but for which we might get very good results. Here it's a proof of concept, a study of only 14 patients were very, very bad condition. The LV ejection fraction was only 16. The cardiac index was 1.3 on average. The SOFA score was 18 out of 24. The pH was very low. Mean lactate was close to 10. And this is the type of patient we implanted with the VA machine. This is a patient here who was clearly dead. The heart does not pump anymore. You can see here the aortic valve is closed. These patients had severe pneumococcal pneumonia, which evolved into refractory shock within 24 hours. And the good news is that in that setting, the heart might recover. This is only 5 days with the same patients with this type of treatment, and the patient was weaned that day with very good results. Once again, this might be tested also in the coming years. Catastrophic pulmonary embolism also might be a good indication. Those patients with the most severe case, the so-called lethal pulmonary embolism, might also benefit of the strategy. They might get the machine to stabilize the patient to bridge the patient to the OR for surgical embolectomy or catheter-based embolectomy. But now I believe that you might use VA in this setting just as the sole treatment plus heparin. You set up the VA machine, you put the patient on high-dose heparin, no need of a thrombolysis in these patients, and just wait. We have now close to 20 cases of this type with favorable evolution. We were able to remove the machine after 1 week, 10 days, without the need of a complicated operation. And the patient, the long-term outcome of this patient is quite good. We are now following up this patient. Last point now, cardiac arrest, probably the most difficult population of patients. Those who develop the so-called post-resuscitation syndrome and might benefit from also these type of machines. This is a series here of 94 patients, and survival at 1 year, long-term outcome was close to 30%. And we have those who have died, clearly, and who might benefit from what is called ECPR, ECMO for cardiopulmonary resuscitation. There's a lot of interest in the literature on that strategy. Here is the landmark paper by Chen from Taiwan showing that the long-term outcome of these patients is better with ECMO than those who do not get the machine. This is another one here in Japan. There is a lot of interest in the Southeast Asia, Taiwan, Japan, Korea, South Korea for this strategy, but it's not that simple. And this is the latest one sent from South Korea. These are real-life data from a huge registry in South Korea in which they collected all the cases who got ECPR, and when they adjusted for confounders, there was no impact of the ECPR strategy on the survival of these patients. So it's very disappointing here results. Hypothermia in that setting was associated with better outcome together with early reperfusion strategy. So we should evaluate these strategies. There's many patients in the cemeteries who might benefit from these machines, but clearly we are investing a lot of energy, money for these patients, and probably we should stick with witness cardiac arrest, those who have very low flow time, short low flow time, no flow, those who got bystander CPR for sure. Cardiac arrest should be of cardiac origin, and the ECMO, the collapse to ECMO time should be limited probably to 45-50 minutes. If you wait more than that, the results are clearly less good. Future trends, combination. There might be a combination also of the ECMO machine plus the Impella. This is a first paper showing that it improved the outcome of the patient, should be repeated maybe with an RCT. We also combine the Impella, the VA-ECMO with the IBP to decrease the incidence of pulmonary edema, just because the ECMO machine increases the afterload of the patient. And there might be new machine. This is the iCore by Xenius, which might be tested in the coming months. These machines is an ECMO machine providing pulsatile flow, which also might be tested in the future. So in conclusion, we need scientific evidence now. This is one of the 10 studies which was proposed by this group in a recent paper in intensive care medicine here, an RCT of VA-ECMO or other type of mechanical device for the management of shock, especially those who have acute MI. Clearly, we might get better results than those obtained with control or the IBP by the shock 2 trial. So this is my conclusion. Clearly, those machines might be able to rescue dying patients. The future is probably to go beyond that strategy and to move on for patients who have cardiogenic shock, but maybe not too late when they have refractory cardiogenic shock, because in all of the paper published so far, those patients who have developed severe multiple organ failure are those who are going to die. If you want to get better results, probably we should move to a much earlier strategy to rescue these patients. So this is my last slide. For those of you who have a little time to come to Paris, come to Paris in 2 weeks from now, where we have a meeting in which we will discuss all these problems and therapeutics. Thank you so much.